Hello everyone, my name is Joshua Acevedo. I'm an SRNA student at FIU, and my project is on improving the incidence of postoperative delirium in the elderly. I want to thank you for participating in this quality improvement project. The learning goals that you will obtain from this quality improvement project are: you will be able to define postoperative delirium, understand the correlation of midazolam and postoperative delirium, understand the impact that melatonin has on postoperative delirium, and we review findings from literature review that discuss the effects of melatonin on postoperative delirium. So what is the difference between delirium and postoperative delirium? Now, delirium is an acute onset of impaired cognitive functions and disturbance in attention and awareness that is not correlated to a pre-existing neurocognitive disorder. It is multifactorial, and the key to delirium is its an acuity of onset. It usually appears within hours to days and fluctuates during the course of the day. Now, postoperative delirium occurs upon emergence from anesthesia and can proceed throughout postoperative days 1 to 3. This disease is also multifactorial, but is thought to be caused by oxidative stress, immune activation, and neurotransmitter imbalance. So, what are some risk factors for postoperative delirium that we should be aware of? A patient who has multiple comorbidities, high operative stress surgeries, for example, a hip surgery or cardiac surgery, history of falls, alcohol use, a previous history of cognitive or functional decline, and advanced age of 70 years or more is a well-recognized major risk factor for developing postoperative delirium. Consequences of postoperative delirium include increased morbidity mortality, functional decline and cognitive impairment, prolonged hospital stay, higher morbidity and mortality, and an increase in healthcare costs. One can expect an increase of postoperative delirium to increase due to the global aging population. In the United States, costs are estimated to be 38 to 150 billion annually. Inpatient costs due to an episode of postoperative delirium is estimated to $20,327, and total costs to our healthcare system of delirium episodes in the Medicare population are $32.9 billion. What is melatonin? Melatonin is the principal substance secreted by the pineal gland. Melatonin is involved in our circadian rhythms, in synchronization, also including our sleep-wake timing and blood pressure regulation. It is also in control of seasonal rhythmicity, including our reproduction and hibernation. Melatonin also has an important role in oxidative stress as an antioxidant. As we know, melatonin is also given as a dietary supplement to treat sleep disorders such as insomnia. Let's talk about exogenous melatonin. IV melatonin is rapidly distributed and eliminated. Half-time is 0.5 to 5.6 minutes. The bioavailability of exogenous oral melatonin varies and it is dose dependent. Low doses of melatonin result in a peak serum concentrations that are within the normal nighttime range. Some other additional benefits of exogenous melatonin include decreased aging process from lack of sleep. It provides anxiolysis, anti-inflammatory, analgesic, and oncostatic. Now we're going to speak on some findings on my literature review in regards to melatonin and postoperative delirium. 2 randomized controlled trials utilized melatonin before surgery and consecutively postoperative to compare the administration of a placebo versus melatonin, exogenous melatonin, for the evaluation of delirium. The dose in these two studies varied, but in one, participants received 0.5 milligrams of melatonin or a placebo every night for 14 days until they were discharged. The evaluation of these assessments were done utilizing the CAM assessment. Results included exogenous low-dose melatonin administered nightly to elderly patients effectively decreased the risk of delirium. Another study included using Ralmeton, a melatonin agonist that shortened ICU stays of critically ill patients. Results demonstrated that the occurrence rate of delirium was 24.4% in the group and 46.5% in the placebo group, where the difference between these two groups were statistically significant. To continue on further findings of my lit review on melatonin postoperative delirium, one intervention group received exogenous melatonin 3 milligrams and was evaluated using the CAM tool on the day of surgery compared to 3 days after. In the elderly patients who underwent open heart surgery, the incidence of delirium was reduced significantly. Another group had underwent cardiac surgery and received a placebo versus 5 milligrams of exogenous melatonin. The participants received 5 milligrams the evening before the operation and continued until postoperative day 3. Delirium developed in 20.8% of the patients from Group A and 8.4% of the patients from Group B, with the incidence of delirium between the groups being statistically significant. Literature findings on midazolam and postoperative delirium. Among 1,112 patients, a benzodiazepine was given in an awake patient without delirium and was associated with an increased risk of delirium the next day. 7.5 milligrams of oral midazolam was administered 30 to 60 minutes preoperatively and evaluating using the CAM ICU method in the PACU. Of these 214 patients, 49.1 tested positive for delirium during the PACU stage. Unfortunately, there is no gold standard for prevention. What we can do as providers is to enhance knowledge in identifying these risk factors preoperatively. And we can compare the usage of melatonin versus midazolam in reducing the incidence of postoperative delirium. To summarize, melatonin has demonstrated benefits in restoring the normal circadian rhythm, which is an essential factor in producing postoperative cognitive dysfunction. A dose of melatonin for decreasing the incidence of postoperative delirium has not yet been identified. Despite having a standard dose, all studies demonstrated a reduction in postoperative delirium development. Additional benefits of melatonin include improved sleep and decreased length of stay of the ICU. Now, with midazolam, sedation led to a higher incidence of postoperative cognitive dysfunction 7 days after surgery. To conclude, future studies are recommended for evaluating the effects of melatonin and midazolam postoperatively on elderly patients, including evaluating on various procedures. Future studies to further evaluate the effects of comorbidities and medication usage when assessing the role of melatonin in improving cognitive dysfunction are recommended. And this concludes the end of my presentation. Thank you again for participating.